Okay, so thank you for those who could join. We are just excited to welcome Dr. Kendra Hotz. Dr. Hotz is an associate professor of religious studies and chair of population health at Rhodes College. She focused most of her work in her career in research on just how race and faith and healthcare inequalities impact communities of color. I have an interesting story about Dr. Kendra Hotz. While I was doing my thesis, I came across her article, and it was the one about Big Mama. Basically, Big Mama's got sugar, I'ma have it too. Mm. And I was like, oh my gosh, there was a term in there that really caught my eye, and that it really explained how I was feeling about my own health at the time, and just really not taking my health in my own hands, and just thinking maybe I was just going to end up with whatever my parents and grandparents had. So the term that I really love in her article, and she will tell you that she did not coin the term, is called medical fatalism. So, and it's just the idea of that I can sort of have some control over my own health. So, of course, like any student, you're going to reach out to the author of the article. And I reached out to her, and I was just like, oh my gosh, I was really fascinated, and I really just wanted to tell her thank you for writing the article, because sometimes one of the hardest things that it is to do is just really just to try to figure out like what words you're going to use to describe what you're doing or how you're feeling. So I would just like to welcome Dr. Kendra Hotz, and she's going to talk to us about how to connect our health to basically our background. So thank you.
Thank you so much for the invitation. It's pretty rare when you write an academic article that anybody reaches out to you having read it at all, or really connecting with it. So that was a thrill for me. What I want to do is not so much talk to you as facilitate a conversation and listen to you. So let me just tell you a little bit about the project and where I am, because where I'm situated geographically is really important for understanding this work. I'm in Memphis, Tennessee, which is Mississippi Delta. It's a very poor region of the country, just economically very poor. And there's also a really kind of dense concentration of African Americans here. And of course, that's not accidental, that it's both very poor and very Black. A long history of policy put those things together so that we have racialized poverty. Well, the biggest impact, the kind of, for me, the clearest way of seeing what injustice does to our bodies is to think about the way that feeling out of control produces stress for us. This, since our ancient ancestors were threatened by, predators, our bodies are designed so that when we feel stress, we can survive it. But the assumption is the stress we feel is something short term, that goes away, that you feel like, oh, there's a bear chasing me, and you run away from the bear, you fight it off. That's called our fight or flight response. And you survive, or you don't. And either way, the stress is over pretty quickly, right? And that fight or flight response, what happens is there's a part of our brain that perceives a lack of control. And when we feel like we lack control, it sends electrical signals to the pituitary gland, which translates those into a hormonal signal that's received by the adrenal gland. And that produces cortisol, a stress hormone. What that stress hormone does is speed up your heart rate, so that you can, oxygenate blood efficiently and run away. It also produces this coagulating agent called fibrinogen that it releases into your blood so that if you're injured, you don't bleed to death. And it slows down how quickly you use up blood sugars, because you want to have a ready source of energy. You don't want to burn through all of your sugars and then not have anything left to run with, right? So that's what our bodies are designed for, on the assumption that the thing making me feel out of control is a predator, like a bear or a lion. But poverty and racism, of course, don't work like that. It doesn't feel like, boo, and you're stressed, and then, whew, that's over, right? It's just this kind of relentless, grinding, never letting up feeling. And your body doesn't know that the problem is racism. Your body doesn't know the problem is poverty. Your body thinks, okay, I'm feeling stressed. I don't feel in control. I know what to do. I go into fight or flight mode. And the result is that the level of cortisol in your blood is called your allostatic load. So the result is that you have this really high allostatic load on a permanent basis. And think about it. If your heart rate stays elevated long term, that's going to be associated with all kinds of cardiac diseases. It's also going to be associated with hypertension. If your blood stays, thick, that fibrinogen, then you're going to clot more easily. And so you'll get a lot of strokes. Memphis is the stroke capital of the US. And if you have a consistently slow insulin response, that's type 2 diabetes, right? And so what you see is that these external factors producing a sense of being out of control are directly producing a disease like diabetes. And it's more than that too, because your body being constantly stressed is aggravating to the body. And so your body will produce inflammation, and that inflammation will prematurely age us. So when Sean puts up all of that stuff about sugar and inflammation, that's not just about diabetes, right? The way that sugar is linked to inflammation is also about all of the ways in which our bodies age prematurely. So that's the context I'm living in, one in which we've got high levels of racialized poverty, and therefore a population that is not because of something psychological or emotional about themselves, but just objectively their external circumstances are putting their bodies in a state where they're far more likely to become diabetic. And you compound that with the fact that our food system is just so messed up. And I'm really grateful for all of the links you put up on the site showing sugar's hiding in everything. It's in your ketchup, it's in your, salad dressing, it's just everywhere. And the foods that are least expensive are the ones that are most likely to have those kinds of sugars in them. So you've got a population made poor by injustice, kept stressed by racism, with bad access to food, and it's just a recipe for a disaster. Then the group I'm working with was African-American women. Then these women come into clinical settings and they feel defeated from the beginning. They feel like there's nothing they can do. It's hopeless. Everybody in my community has sugar. I'm going to have it too. And their physicians write them off as you're fatalistic, right? As though it's your fault, you've given up. So the article and a lot of the other work I do are primarily designed to educate physicians to think differently about their patients. First of all, to recognize that when you just give people a prescription and you just tell them to follow a different diet, you don't know what neighborhood they live in. You don't know if they have access to a grocery store. You don't realize how expensive nutrition is. One of the women pointed out, these doctors don't even know what a gallon of milk costs. And her point was they got so much money, they don't have to worry about a gallon of milk. They just buy it. They don't care how much it costs. They don't even know how much it costs. So you've got a physician population just out of touch with those realities. That's one side of it. There's a piece of fatalism that is a realistic assessment. My life circumstances are such that not me personally, right? The women I'm working with, that they'll say, I just have limited control. And that's not a psychological problem with me. That's just a realistic assessment of my circumstances. And the physicians don't understand that. And then the other side of that is they're saying, but I do have some measure of control, and I'm going to take control in the places where I can take control. And so that's where I found just this incredibly powerful discourse about not claiming it, which the doctors were totally misunderstanding. I didn't understand it. They just had to explain it to me. that this was a way of saying, I know I've got the world against me, but I'm pretty strong. And I'm going to find a way to make community with other women, and we're going to support each other, and we're going to find a way to defeat this thing. And my gosh, I'm in awe of these women. The challenges they face and the strength they have it's extraordinary. And then when I saw, when you invited me into the Sisters Breaking the Bonds of Sugar, I was like, oh my gosh, this is it all over again, right? I mean, you're doing here online what I've seen women doing in person, face to face in Memphis. So just kudos. It's such a powerful model. Um, and what I'm amazed by is I come on there thinking, well, I'm just going to peek in and see what these women are talking about and what they're doing. But then I end up learning all of this stuff. Like, you put a video up and I think, I didn't know that. Right? So it's been good for me. I've become more conscious about my own sugar intake just from being an observer. So I said I wasn't going to talk too much, and then I think I just talked for 10 straight minutes. I apologize. I get excited about these stuff.
No, I think that's why we're here. I'm, if you don't mind, I'll start with a question though, and I think it's just really, I guess as a nurse, you're so used to pulling information from the medicine side, the nursing side, and so I thought it was odd that you come from a theological background, and also adding on the womanist sort of perspective, and that you were able to put so much into really 2 articles. So I guess one thing that I would just kind of like for you to explain is, like I guess my thing is like, what made you go there? Because so many people aren't going there. They're just kind of, doing this like high level research, doing these surveys and getting the data and just making it, just something that somebody can read. But yours was more qualitative, and the words meant everything. You would have to really read the article and find out what the ladies were talking about too, to break it down. So I'm guessing, how, I guess my thing is just like, how did you go about doing that? What made you, as a theologian, say, I'm going to look into this?
That's a great question. In some ways, I think I came at it differently precisely because I'm in religious studies. Um, because I take seriously the way people are shaped by their faith communities. And a lot of people who study health think of religion only when it's something that they think, well, that's in the way, that religion is an obstacle. This person won't let me do what I want to, the physician will think this person won't let me give a blood transfusion or doesn't want to take these pills. And it's because of a religious motivation. And I thought of religion as a source of strength and an asset. And so I wanted to hear people thinking out of their faith traditions about their bodies. So I came to Memphis from Michigan, and I was in an extremely white part of Michigan. I could go days without encountering somebody who wasn't white. And I moved here, and there was something really exhilarating, first of all, about being a racial minority for the first time in my life. Memphis is about 60% African American. And there's this incredibly rich culture here. This is the home of the blues, birthplace of rock and roll. I mean, we like to brag about these things in Memphis. And there's this kind of vibrance and strength. And so part of it was, I had moved here and I thought, well, I better learn where I am. I better find out who my neighbors are. And Memphis has got a lot of 2 things. Well, I mean, it's got a lot of like barbecue and stuff, but I'll leave that to the side for a minute. It's got a church on every corner, right? And Memphis is the epicenter of health disparities in the US. Our rates of hypertension, stroke, diabetes, infant mortality are off the charts. And I thought, what is going on? Like, this doesn't seem right to me. And so I started just thinking about, is there any relationship here between faith-based communities and health? And then I started working with, as the article points out, Church Health Center, which is a faith-based healthcare provider. And it just snowballed from there. I like listening to people, in spite of the fact that I'm doing all the talking here. I like listening to people. I like listening to stories. I like hearing the way people make sense of their experience. And as a scholar, I think the best work I can do is to take the wisdom of religious communities and present them in a way that people in power will listen to. So just to be blunt about it, if you look at the women in that article, Georgia and Tamara and all it, the doctors aren't going to listen to them. It's not right, but they're not. And they will listen to me. I talk like they do. I look like they do. I move in the spaces they move in. And so in large measure, I feel like I have this moral obligation to take the wisdom of these women and make sure that it gets heard. And I'll also admit, so one of the things I worry about, like, the things that bother your soul, I worry about exploiting my conversation partners. They share their stories with me, and I don't want to be this sort of colonial force who's taking the raw material of other people's stories and translating them into something else. So that's from my own, like, that's something I have to be super careful about myself. And I probably fail at that sometimes, maybe a lot of times.
Okay, Ross or Sherry, did you have a question? Because I can go on and on. I'll, if you're preparing a question, either one of y'all, one of the things that the article starts out just basically talking about how we can adore people and we look up to them. So that aspect of Big Momma's Got Sugar, Imma Have It Too, they are these respectable women in the community that we do sort of say, if I can be anything like this woman, then it's good for me, right? So I just, the one thing that that seems to be kind of something that stands out in the medical community is sort of linking diabetes, hypertension, and all these other diseases with a lack of movement. In some of the hardest working people that I know, or women that we're talking about, like the church, respectable women who working hard on their feet all day, cooking, cleaning, so I just think it was just a respectable way to start an article too, by just saying, if she's got it, I'm going to have it too, but also saying, how can I break away from this? So I thought it was really respectable.
Well, I had never heard, I had never heard that term, medical fatalism, and I can so relate to that. My mother had, and my father both had diabetes, high blood pressure, oh my word, you name it, and they had it. And they were on dialysis before they passed away. And my mother died when she was 62. And I thought, oh my gosh, is this going to happen to me? I was like frightened until I passed 62. And I didn't have anyone to say, like, don't think like that. Or my head was like, oh my God, I'm going to die too by 62 if I make it to 62. So I understand that. And what Sean was saying about, when you see someone, you want to be like them. I wanted to be like my aunt because she was my idol. And my grandmother was a big woman. Mama was big. And I want to be like Mama because she was big. My mother was not a big woman, but my grandmother was. And so anyway, I passed 62 and now I'm 68. So I think I'm okay. But, I do what I can to take care of myself because I have diabetes, high blood pressure. What else do I have? High triglycerides, high cholesterol, you name it. Yeah. And I don't want to go on dialysis like my mother and father had to, So yeah, that was a term I'd never heard before. And I was really intrigued by that term.
Yeah. Yeah, I'm always amazed how powerful it is to find language to describe what you're experiencing. That'll happen to me sometimes. I'll run across a term and somebody's explaining something and I think, oh my gosh, I've experienced that. And it doesn't change the fact that I'm experiencing it, but it feels empowering to say, there's a name for that, and I can put some control to it. There's actually some good neuroscience behind that, that being able to name our experiences lets us feel a sense of control over them. And if you remember, the root mechanism for these diseases is the feeling of being out of control. And so anything you do to find a way to claim control is powerful. Even what you said at the beginning, when you said, I don't say, oh, that's okay anymore, I say, thank you. That's a really empowered thing to do, because it's not okay to leave you waiting all that time. And you diminish yourself when you go, oh, don't worry, that's okay. I don't matter that much. For you to say, no, my time is valuable, and thank you for acknowledging that. I mean, that's an empowered thing to do. And so every little thing like that you find is sort of building this snowball. And the bigger the space in your life you feel that you can claim control over, or the less you feel controlled by external forces, the stronger your well-being will be. This is one of the reasons I think so many researchers misunderstand religion, because they think people will say, oh, God is in control of everything. And they'll think, oh, that means that these people are fatalistic, that they're just handing over control to God. But of course, that's not how faith works. Handing over control to God is a very personally empowered thing to do. It's not like being controlled by an employer or by an abusive relative, or being dismissed by healthcare providers. It's a form of giving control that is, you can't, God doesn't take that control from you, right? It's something that emerges from you in a relationship. And so I think that in my experience, people who have a deep sense of faith are more likely to find, it's kind of a paradox, but they're more likely to find ways to feel a sense of control in their lives, including naming what they're feeling.
So I have a question about, and the way you talked about the doctors and working with them. And one of the first things that you do when you go to the doctor's office is you fill out a family history questionnaire. So how do we get them? And from my own experience, I have been on blood pressure medication for probably 15, 20 years. I've gone to the doctors on occasion where my blood pressure has been 106/60.
Ooh.
Almost passing out. And
Yeah.
so just to have the conversation with the doctor about, okay, I really need to get off of this medication. And it's like pulling teeth to get them to work with you to take you off of that medication. So, I'm trying to take back that control on my own. So what can I do other than just saying, hey, I'm not taking that anymore, because, there are days when I'm stressed to the max and I know my blood pressure is through the roof. So that medication is helpful, but those questionnaires, instead of them being used as a tool to assist us, I see that as just their ticket to how they're going to continue this path for us. So I want to break that.
Yeah. I'm looking something up real quick. I want to give you a reference, and I'm going to forget the guy's name. I'm doing that cheat thing where I Google something real quick. Sorry. There is this book called How Doctors Think, and it's by, here's what I was looking for. What the heck is the guy's name? I teach this book. I should know his name. Jerome Groopman. It was his first name I couldn't get. I can put that in the chat in case you guys are.
And the most interesting thing about it, my doctor is a female, Hispanic female. And I've watched her weight balloon over the years. And whenever I would go, she would tell me, oh, watch your diet and you need to lose 10 pounds. And I'm thinking to myself, what are you doing? And that's just me, but.
No, I hear you. I mean, I think that, so there are some studies that show that women doctors are better listeners and more responsive. They practice what we call patient-centered care. But it's also true that physicians are all socialized in the same way. So there's some good studies showing that there's a way of measuring empathy. There's an instrument called the Jefferson Scale of Physician Empathy, the JSPE. And they'll administer that to physicians or to students when they enter med school. And then they test them again, sort of at the end of the third year when they've been doing their clinical rotations, and they find that empathy drops. They become less empathetic. There's something about medical school that does that. And then you can test again during residency and empathy drops again. So there's something we're doing in the process of medical education that is reducing empathy. Women still have higher levels of empathy and it reduces less than it does for men, but it's true for women too. So even when you find a healthcare provider who's from an underrepresented population, an ethnic minority, a woman, they're still socialized in the same way. And so you have to think about, how do I manage communication with my doctor? So what I like about this book by Groupman, How Doctors Think, is it's essentially a manual for patients that teaches you, this is the way your doctor's been trained to think. And here are some techniques you can use for disrupting that process, helping your doctor do a reset and think differently. And some of the techniques are incredibly simple, like this sounds dumb, like it wouldn't work, but it does. Asking, what else could it be? So they're trained, they use this decision tree model. You're telling them, I've come in for this and this and this, and then they hear something that sounds like a symptom and they say, oh, wait, did it feel like this or that? And you say, it felt like this. Okay. Was it A or B? It was B. Okay. See, and they're just following this decision tree. And at the end of it, they say, here's your diagnosis. 1 in 7 initial diagnoses is wrong. I mean, just process that for a minute. 15% of the time, the first diagnosis is wrong. And it's because they fixated on that first symptom and followed the decision tree instead of listening holistically. And so if they will listen holistically, it takes a little longer, but they're more likely to arrive at the right diagnosis, and they're more likely to arrive at a plan of care that's workable for that patient, so that it's more of a kind of shared decision-making process. So because they've got to the end and they've made their diagnosis, then they have this risk of what's called anchoring bias, which is to say, once they've made up their mind about you, this is what you need, they stick with it, right? And what you want to do is figure out, how do you get your doctor unanchored, right? And so some simple techniques are just to say, well, what else could it be? Like, what are the other options? When your physician proposes a plan of care, saying, well, here are my goals. Are there ways that we can meet halfway, right? And so this book, the appendix, has just a list of really, really great techniques. If you want to know why they work, read the whole book. If you just want to know what works, use the appendix, right? It's just a terrific resource.
I just came from my doctor talking about doctors, and I got to tell you, I feel very blessed because, first of all, she was an hour late, which she never is, and she apologized, and I said thank you, because I don't say, oh, that's okay, don't worry about it. No, 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 I just say thank you. But she is the best doctor I've ever had, and she is very caring. And normally when you go to a doctor here, you have 2 things you can bring to them. You got 15 minutes, you're done, you're out. This woman before me was in there an hour. I know, because I watched my watch. But Dr. Borgo would have sat with me for an hour and listened to me. And what she says at the end, is there anything else? She is so wonderful. Anything I need, she sends me for it. I feel very privileged and blessed to have her because she's just awesome. And I will go wherever she goes because she's leaving the university. But I don't want to take up a lot of time, but I want to tell you something. I worked for the University of Ottawa as, I forget the term now, but as a patient, and I pretended I was a patient. And these were students, I forget the term, but these were students.
Standardized patient.
Hmm?
A standardized patient.
Yes. And these were doctors who were going out to be doctors. I want to tell you, some of them I wanted to just slap because they didn't have a bit of bedside manner. They didn't listen. And I was like, and you have to stay in your role, right? And I was like, are you friggin' kidding me? And you can't change your face. You have to, and you can see what I'm feeling by my face. They didn't listen. Many of them did not listen. And I told on them too. Would you go to him? Nope, not in your life.
Yeah.
And that was quite a wake-up call. So I'm very blessed to have the doctor I have. She's awesome.
Yeah, I want to thank you for that service. Those standardized patient encounters are some of the most important things for rising healthcare providers, and they need that honest feedback. They need to hear, these people said that they wouldn't go to you as a doctor, and here's why. And that's powerful feedback. One of the things my doctor does that I really like is she has a little whiteboard. It's just about this big in the office with a pen on it. And while you're waiting for her to come down in, you just write down on the whiteboard anything that's on your mind that you want to talk about. Because she's learned that a lot of times patients come in with a list of questions, but then you get busy with, looking in their throat and listening to their heart, they forget. And so while you're waiting for her to come in, you just jot down those notes, and then she can look down and say, oh, I see you wanted to ask about, whatever it is. I love that practice. Yeah.
That's awesome. I was going to say, one thing I wanted to highlight and why your article is so important for the medical community to read is because you're saying that studies have shown about 1/7 of the time that the diagnosis is wrong. But I think in this community, we can all identify with if the communication level is off, which is the reason why you had to come up with this article, then I think it's wrong more than 1/7 of the time for communities of color. I would like to say probably half the time it's wrong, because it just seems like if we're not even starting with that you, first of all, want to hear my story. Secondly, that when you do listen to my story, the language is not even what you understand. And then you cut off and then start your decision tree, then we've missed some windows there. So it made me think about as a nurse, how do I get this information out to the medical community? Because it seems like, yes, that was studied and it was done in Memphis, but probably it needs to be done in an area in Texas, so that, because there's language that develops in Texas in communities of color that are different than Memphis. So I guess that's just one of my questions, is how do we get that out to the medical community?
Oh boy, you are asking the burning question for me. Before we started recording, I was talking about the program. I'm the director of the health equity program at Rhodes College, and we've recently been contracted by a healthcare system, a big healthcare system in the county, to do education with medical residents. And so we get them for 1 month each of their 3 years in residency, and we do this deep month-long immersion. And what I tell them is the main thing you're doing this month is you need to know your place. And I use that language deliberately because it sounds insulting at the beginning, right? Like, you better know your place. But I mean it quite literally. You need to know where you are. And that means that I have them do things like check the charts and find out the most common zip codes for your TennCare patients. So TennCare is our version of Medicaid, right? Find out where are your lowest income patients coming from. Find out what neighborhoods they're in. And then we're going to go visit those neighborhoods, and you're going to get there on the bus. And so, I have them go to Smoky City, Klondike, and they got to get on a bus in Smoky City and get themselves to a healthcare appointment by 9 in the morning. How long is that going to take you? You're going to get on the bus from Binghamton and go to your nearest Kroger. That's a grocery store. Can you get back in August before your milk spoils? And so it's these very simple practices of learning. Most healthcare providers come from affluent backgrounds. Not all of them, but the vast majority come from pretty privileged backgrounds. They're disproportionately white, still disproportionately men. And they just don't have the life experience to really understand the struggles their patients are facing. The result is that they tend to blame their patients. Why didn't they just take the medicine? Why aren't they just exercising this amount and so forth? I always tell them, if you are asking, why don't they just, you're not asking a question, you're making an accusation. And so what you need to do is get curious. And instead of saying, why don't they just, shift that and say, I wonder why. Like, let yourself be genuinely curious. Why did that patient not take that medicine I prescribed? Well, let's learn to think about why, right? Was it affordable? Is there a pharmacy in their neighborhood that carries it? Is it open during the hours when they're not at work? Does it make them unable to operate equipment that they need to use at work? Did they miss the appointment because the bus system isn't working or because it's late, right? Just trying to get used to thinking that people have good reasons for what they do. And instead of assuming that people are stupid or lazy or ignorant or uneducated, think instead what might be a hurdle they're having trouble getting over. And even if you can't help them get over that hurdle, you can at least be more compassionate. And because you can tell when somebody's judging you, right? You can tell when you're being blamed, and that's going to shut down communication. In an ideal world, I think we would get greater affiliative overlap. That's not the right way to say that. We would get more physicians from low-income backgrounds, from racial and ethnic minorities, whose first language is in English, right? We would get healthcare providers who look like the community. But that's not likely to happen soon. And so in the meantime, what we need is to figure out ways of teaching people compassion as a practice. So I always tell people, I don't care what's in your heart, I care what your behaviors are. So if you have some implicit bias and can't fix that, at least you can keep yourself from hurting people with it. If you are worn out and you just don't have any more empathy for the day, I understand that happens to all of us, fake it, right? And so I think in a way, you don't need to replicate the study in each place. Instead, what you need is to develop networks of providers who are committed to developing the practices that help them know their place. And I believe that when they get to know their people better, they'll be able to provide better care. I'm sort of assuming that familiarity will breed compassion and not contempt. I might be wrong about that.
That's a good point. Wow. I think, Sherry, do you have another question?
Yeah, so I really like your comment about, because I say every day or all the time when I talk to people, assume good intent. You know, I'm an ethics officer, and people can really do some interesting things. And when it comes down to, investigating or looking into it or looking into the root cause, people can often go off on these tangents on making assumptions. And I'd say, 95, I would say 97% of the workforce comes to work to do a good job. Nobody intends to do these horrible things. So I think the same thing about some of the physicians, but I think that they're not being trained, like you said. And if we as patients could have the tools to kind of stop them in their tracks and redirect them. I think that'll work best for all of us in the end, because I think about my doctor, you know, like I said, for years, I've been trying to get off the blood pressure medication. And this last time, thanks to Sean and her awesome support system. So I lost like 15 pounds between appointments. And she was like, oh my goodness, what did you do? Because I've always worked out. That wasn't an issue. But when I did that, you know, we had longer conversations this last time than we've had in a long time. So I kind of got her attention with that. But I think if we as patients could get some of those little nuggets, like you said, to kind of ask them the questions, what else could it be? And how do we get this information out to our communities so we can start helping ourselves? I tell people all the time, help me help you be the hero. So how, you know, I want to get these nuggets out to our community. So if we work it from both ends, I think we'll all be better off.
Yeah, yeah. That simple question, what are my other options? I'm not saying I just want to drop this medication because I'm somehow, I hate the term they use, health literacy. I don't like that way of talking, but that's the way they talk. You know, you want to say it's not a lack of health literacy. It's actually a kind of passion for knowing more. So what are my other options? If I weren't taking this medicine, how else would I manage this? Those are the kinds of things that kind of help break that automatic circuit. Well, this is your family history. This is what I prescribe. Off you go. And I like the idea of working both sides of it. And wow, congratulations on the weight loss. That is tremendous.
And it was total, I wouldn't say it was accidental, but just being aware of the sugar that's in everything, reading the labels. If I make the decision, I'm making an informed decision now versus, you know, having 50 grams of sugar in my breakfast.
Yeah.
You know, so.
Yeah. You know, I was talking to, I'm doing a study right now with a group of Black pastors. And I was talking to one of them and he said, this stuck with me. He said, you know, I feel like white people get treatment and Black people get pills. And I said, why do you think that is? And he said, I think it's because the doctors don't believe that we will do the work it takes to stay off the pills. So he said, I don't think they'll educate me about nutrition and exercise and so forth because they don't think I'll do it. It's easier just to give the pill. Now, I don't know if he's right about that or not, but I thought it was a really interesting way of framing the medical encounter. And I wonder if I feel fairly empowered when I go to the doctor to say, hold on, that's suddenly you want to put me on this medication. I need to know more about that. And what are the side effects and what are my other options? And I never worry that the doctor's going to think that I'm being inappropriate or that I'm being, I'll use a loaded word, uppity, right? They will receive that from me, partly because of my social class, partly because of my race, partly because they also know that I'm the ethicist who works in the hospital, right? So, but I think there are other patients who might do that with a physician and the physician would receive it as being aggressive and you'd get labeled a difficult patient. And so figuring out, like, I feel like my job is to help healthcare providers avoid that trap, right? So that the burden shouldn't be on the patient. But the reality is you do have to figure out, how do I present myself to my doctor in a way that they won't dismiss me? That's not fair. I wish the world weren't that way, but I don't, lacking a magic wand. I think the best I can do is say, figure out some techniques that work with your doctor.
I have learned so much what Shun puts on our Facebook page. And one of the things, like, I don't even think about this. One of the things I really got into was about the soul food and the history of soul food, going back to slaves, like, oh my goodness. And then the other thing was, in certain neighborhoods, some of the stores won't go in the neighborhood. So when you're talking about the doctor doesn't know, like, if you're living in a neighborhood and you can't get good stuff and you don't have the money to get the good stuff, the doctor doesn't know that, and probably they're like, whatever, you know. So yeah, so many things on there about the soul food, back to slavery, you know, and all those things. Oh my goodness, I've learned so much. And like, I live in Canada and I've born, brought up, this is my home. And so I haven't faced some of the things, you know. Some of our Aboriginal brothers and sisters have, but yeah, I feel very blessed when I'm reading some of the things, you know, and hearing some of the things that Shun shares with us. We're just really blessed to have so much information given to us. And she doesn't preach, you know, she just puts it out there and we take it in and do with it what we need to do with it. So it's been really wonderful. But I'm so glad you're here tonight. Thank you so much. And thank you for reminding me about standardization. But anyway, yeah, I've learned a lot.
It is such, I love this Facebook group. It is such an empowering community. And I do like the way you find, she's right, you don't preach, you find accessible information, you put it out there and you wait to see what people will do with it. And it's clear that a lot of the women on that page are really taking that, you give them that power and they're taking it. And sometimes it's just, I'm cutting a few grams here or there, but it adds up. It's very impressive. In the US, Roz, I say for any health disparity, any racialized health disparity, if you ask why is it that way 5 times, so you know that root cause analysis practice where you say, why is it that way? Why is it that way? And you keep kind of backing up. In the US, for any racialized health disparity, if you ask why is it that way 5 times, you will end up at slavery. Like that is the root cause. And we have not come to terms with that. And until we do, we're not going to fix this problem, which is one of the reasons, as much as I want people to individually empower, most of what I do is not about individual empowerment for people in communities of color. Most of what I'm doing is talking to people in power, saying, you have to come to terms with this, right? Because until we change the power structures, it's totally unfair to hold people individually responsible for what happens to them.
You take COVID, for instance, on the news, what I hear is, you know, this has affected the Black community. And it's like, because they don't have access to care, like, that's frightening. That's sad. God help us. Like,
it's more than that, though. It's not just healthcare. So you remember that dynamic where your cortisol goes up because you feel threatened, right? The other thing cortisol does is disrupt circadian rhythms, because you don't want to get sleepy just because it's dark outside if you're being chased by a bear, right? So cortisol disrupts circadian rhythms. Disrupted circadian rhythms suppress immune function. So you get a population that is more susceptible to infection. And because of a long history of racist housing policies, that same population is living in housing dense situations where they're going to pass those infections, and they're more likely to be working in low income, quote, essential worker positions, like as a grocery store clerk, who can't practice social distancing. So a lot of what I heard was people saying, well, yeah, we're getting more infections in African American communities because they're not social distancing, they're not wearing their masks, blah, blah, blah. And I'm like, what? Are you paying any attention at all? You know, so seriously, if you ask why 5 times, even on COVID, you end up with slavery as the root cause. Which I don't want that to make people feel hopeless.
No, you don't make me feel hopeless. I'm just like, it validates, you know, so much, you know, and especially when we're talking about food and food sources, you know, and where we happen to end up and where we live and how we eat, you know, so it just makes total sense to me. I know we can't do this all night long. So I'm going to end on something that I love. I'm sure everybody on the platform is familiar with Fannie Lou Hamer. And one of the things that she said that has always stuck out in my mind is, you can pray until you faint, but if you don't get up and do something about it, God ain't gonna put it in your lap. So when you use things like that from people who know the struggle, first of all, who can identify with struggle at its finest, and then turn and use like God in a powerful way to say, hey, you got to even help God out in some situations. That's the language that empowers us to make change. So I think I just want to end with a very huge thank you. I think that I have been a fan of yours this is going into my second year, and I'm just gonna follow you. And I appreciate you being a sister in the community of sisters breaking the bonds of sugar, not just as a one of the things I don't like is window shopping, but you're in there with us, and you understand the struggle. And I do know that the one thing about the civil rights movement is that if we didn't have our sisters and brothers of other mothers, that we want to say, it probably would be a different outcome. We know that today. So I just appreciate you being a part of the community. We appreciate it. And, thank you for your time.
Thank you for yours. I'm so grateful. All the work you're doing on this Facebook group really is commendable. I'm just so grateful for you.
And I thank you for the two questions that I'm taking to my doctor when I go. What else can it be? What else can we do?
Yeah.
I love that. Simple questions, but major.
Yeah.
So thank
Very
you.
simple. All right.
Thank you, Dr. Holtz. Thank you for being here. It's been great.
It's just Kendra. I'm not your doctor, just Kendra.
Listen, I worked in the operating room, and there were some people I could call by their first names and other people, doctor. And where I just finished work, where I retired, it was the same thing. Everybody, but I'd say, nope, Dr. Moore. He goes, Len. I was like, no, can't do it.
Right.
Anyway, thank you so much, Kendra,
All right.
for being with us.
Thank you very much.
Everybody.
Thank you.
Thank
Good
you.
night, everybody.
Thanks, Sean, for
Good
organizing
night.
everything.
Okay.
Good
Thank
Bye,
you.
Sherry.
Good night. Good night,
Sherry.
Ross. Good night, Kendra.
Thank you, Sean. That's been great. Yeah.
Thank you so much. I appreciate all of your support. You know that. So thank you. We'll talk later.
Thank you. Thanks for everything.
Okay.
I'll message you at some point.
Okay. Thanks.
All right, love. Take
Bye.
care.
Love
Love
you.
you.
Bye.